Appreciate it. And good afternoon or good morning to all of you today. I wanted to take the time to talk a little bit about Boomi and our positioning of our healthcare market and its use of enterprise E-IPaaS, and talk a little bit about the strategic approach that informs our customers and our clients' use of the platform. And I think I wanted to start off a little bit, just take a moment to explain the title of this webinar. I entitled it E-IPaaS Unum, and some of you have recognized that being similar to out of many one, that motto, right, for the United States, E pluribus unum. And I think it really speaks to Boomi's approach. And somewhat, I'll take a philosophical angle going forward just to open the aperture and to broaden our horizon into why it's important to make the right technology decisions, especially when you're choosing a hybrid integration platform. And of course, the other varied reasons as to how the healthcare landscape is changing and why it's really important that we make the right strategic technology decisions going forward. The title of this webinar comes from an article in the New England Journal of Medicine from about late May, and it was entitled E pluribus unum, and it tells the story of a young woman who struggled with receiving appropriate health care when she was diagnosed with advanced gastric cancer. She was a recent immigrant and only in her 20s. She was without private or public insurance, and because of her immigration status, she could only rely on her age when it comes to avoiding advanced health-related issues. And I know to many of us or our children, or we'd like to think that we are above the need for complicated healthcare. Hopefully we're all living healthy lives and we continue to do the right things by ourselves and our family when it comes to living well. But for those who are not so fortunate, there are a hidden class of citizens in the United States, about 10 or 12 million, they don't have any health related safety nets at all. And we take that for granted. And I think it's incumbent upon us to be thinking about this as we spend money within our organizations to advance our positioning in the competitive markets. We are a market-driven healthcare system, and we need to be thinking about, those that fall behind, or, how can we position our organizations to be more mission conscious, right? And these are the little things that we need to be thinking about as we go forward and we make technology decisions, and as we become partners with the lines of business and being better aligned with our mission statements, right? That even the young can fall victim to the complexities, right, of the cultural, environmentally challenged healthcare system, right? So what we want to be thinking about when we think about strategy is not just the technical reasons, not just the internal cultural reasons, but what's better for the organization and the competitive marketplace. How are we going to enable the organization to move forward, the integrated delivery network, with all its complexities of dealing with enterprise licensing and the products that they choose, that how can we make the right decisions that fall in line with the issues of equity and social determinism, right? So that's the kind of theme I'd like to weave as we go through this presentation. And I'm going to challenge some of the details that I have in this presentation, and maybe we can follow up afterwards and have some discussion. A little bit first about what Boomi is. Boomi is a integration platform as a service product. We are a SaaS integration and business transformation product. We are the largest independently owned E-IPaaS vendor in the space. We have the largest number of users on our platform. We have the highest rates of renewal and satisfaction for those in our space. And we've been leading in the Magic Quadrant in this space since its inception. So we feel an outsized bit of responsibility to make sure that we represent this Magic Quadrant properly, and that we make sure that our users are happy and are constantly taking advantage of the innovation that we can bring forth on our platform, and to advance the good work that our customers and prospects are doing in the healthcare and life sciences. I think it's important to note that we have differentiation in the platform. We don't just do one thing, we do several things very well. And we focus on the community aspects as well in using our platform, so that we take a lot of the angst out of learning and the supportability from a community perspective out of the equation, especially since E-IPaaS is new to healthcare and life sciences. As we move forward, I'd like to be talking about technology game changers, right, that are driving people to adopting a hybrid integration platform, that those things that seem to be in front of us, but we don't really know how to get a handle on, right? These efforts around aspects of moving to a multi-cloud environment, or maybe a single cloud, just moving out of our own present data center, embracing remotely hosted applications, these types of things, all these cloudy subject matter, are ripe for inspection and conversation with us, and we can help you de-risk your journey and your efforts to creating strategies to adopt cloud native technologies. Big data and analytics, harvesting unknown data silos for greater inspection, for greater value. A lot of folks don't understand in an open and available way what value is actually resident in some of their data silos. There's a lot of applications in healthcare. Many of them lay dormant for a while. There's a lot of new applications coming along and coming online, and there are a lot of applications that have to stay cold or stay available for legacy reporting or for issues of continuity when we're taking a retrospective view into either a patient's health and lifestyle survey, or we're actually looking into our own employees, or looking into our own physicians, right? Or needing a longitudinal view forward or backwards. There's a lot of data that has to stay online in the healthcare environments. And so we need to be thinking about that. And how do we get access to those data? The consumerization of health IT is a very strong driver for change and for adopting cloud-like technologies. And a lot of this experience is driven by the multimedia and social media experiences from the likes of the Facebook, and the LinkedIn now is becoming quite strong, and Twitter, and these types of social media platforms, which are training the end user and the organizations to be much more responsive and to be much more conversational and much more as I say, dare I say, responsible, right, in their rapid fire responses and needs and dislikes as they see that in their communities in which they're serving, or the communities in which they'd like to serve, right? So you have a rich consumerization of health IT, which is ever present and something that needs to be addressed. And all the while, as you adopt new technologies, as it's more than just about the EMR, as it's more than just about the episodic care of the patient, we need to be thinking about security. And so as you adopt anything that's outside your comfort zone, or even in the cloud, we need to be thinking about de-risking that and understanding what that can bring. I'll pause here, and I just want to remind everyone that if you do want to leave a question, go ahead and do that in the chat, and we'll try to take those in stride. So what's really going on here? It's about an adoption, about the accountable care organization, value-based care model, the movement to measure individual health based on population outcomes, capitated models based on group purchasing agreements or predetermined costs for health outcomes, right, based in aggregates. We need to save money in healthcare today, right? And the more an organization becomes digitized, and the more we become more responsive to the care of the citizens or to our subscriber base, the more reliant we are becoming on technology for the care and feeding of not only our individuals, but it's usually a larger care team now at Bay, right? We have family members and non-clinicians that are becoming more and more a part of the extended care teams. And this is by design. It's all part of cost savings, and it's all about adopting fully a value-based care model. The government is aware of these types of reimbursements, the long-term care centers, the skilled nursing facilities, palliative care, all types of environments. Even the traditional hospital are looking to lower total cost by taking advantage of what's available in the home. How quickly can we get people home? How quickly can we get people out of the high cost centers? All of these things are really creating a new vehicle and platform for care delivery. But one of the strongest drivers for value-based care has to be the rich composite of attributes, which is impacting care delivery in the aspects regarding population health. And this slide gives one an opportunity to see just the many aspects of population health and the different types of levers that have to be pulled and managed right along the way. So we're dealing with living longer, not necessarily well, but with multiple chronic diseases. We're living with a physician's shortage, as it were, and we're living with a growing older population with a lessening growth trend of younger population, right? So we're having to deal in many cases with more of a demand and case mix than we have in the past. And the most important aspect of all of this is the cost. And I just got some updated numbers, and we're up to 18.2% of 2020, and that's thanks to COVID. It really kind of upped us up a little bit. So as of 2020, we're at 18.2% of GDP. And what that means is health-related services are costing the United States, of every dollar being spent across the United States, 18.2% is on health-related services. Now, that's an unsustainable rate. It's growing faster than the top 12 OECD countries, so those that are more like us in terms of environments and development. Those are leading with better care and outcomes at spends of only 12%. And they have the ability to save money and to cap their healthcare expenditures and tie it to tax expenditures and things like that. Whereas the United States, we've been growing since about the 60s, since the inception of Medicaid and Medicare, of about, what was it, 2.3%, I believe it is a year, 1.8%. It started off, then 2.3% per decade. We've bumped up a little bit because of COVID. And so, when we think about growth and complexity of health delivery in this country, and we think about the silver tsunami, or we think about population health and the demographics and how care is being delivered, we need to be thinking about how technology can really play an outsized role in this, and how we can be responsible stewards within our own organizations to allowing our missions to develop and to grow unabated, right? Because it's that underlying cause that we are supporting our service lines, right? It's not because we want to be heavily focused on enterprise licensing and legacy architectures, or that we want necessarily a cumbersome EMR. We want to make sure that the technology choices we make are really impacting the bottom line. And the bottom line, as you can see, are quite soft. They're quite real. They impact all of us. And it's something that we need to be thinking about as we make these technical decisions. The cloud certainly is a way to move forward in a low cost way. And I think, it's something that we're going to move with here. I'm going to move to the next slide here.
Let me just pause you for 1 second.
Sure.
Sylvia Jessen just has
right.
a comment and question. She says, the healthcare system in the US does need an overhaul, and we haven't found the right model yet. All of us insured patients are paying for those that are not insured. Do you feel technology is the answer to our healthcare problem?
So, all right, this is a great question. The answers to the problems certainly include technology as part of the solution. Part of the problem is complexity in care delivery, complexity in quality improvement programs and the way care is measured. Part of the problem is due to the fact that in the United States, healthcare politicians didn't necessarily want to make a healthcare decision to negatively impact their constituents. That was something that that all political parties agreed, and that's why the cost just keeps escalating and escalating, because it's very popular to just say yes to healthcare. Up until about 2009, when there was a admonition of that and an acknowledgement, and then it manifests a remedy through the High Tech Act, through ARRA, and we started moving through meaningful use stages, which we could argue were successful or not. But the bottom line is, moving into an era of digitization is definitely one way of supporting the mobility of the patient, supporting lower costs. It's certainly supportive of letting the government, which is the greatest payer of the overall share of dollars, be more mindful and and be able to inspect through the continuum from the payer down, right? The cost and the actual remedy. So is this particular care being delivered the best? Is it evidence-based? Is it really the most cost-effective, right? We can't really do that unless we see the full supply chain, as it were, the costs through the whole episode of care, including the adjudication of the claims and the billing. To make that seamless, you need technology, you need the right codes, you need syntactic and semantic interoperability. You certainly need open and available systems of record. Does that mean we necessarily need an open commons or an open EMR? One would argue, yes, you do. But then you have the traditional software vendors who say, no, I'm going to have a closed system, but I'm going to be open among those that are like me. So you have the Epics and the Cerners and the Meditechs and the McKessons, and some are better at being open and available than others. But it is a market-driven healthcare system. So, a lot of issues around interoperability and technology openness has its genesis in an enterprise ISV model, which really is about protecting their footprint. So, not getting too much into the history of why we are in this situation today, what Boomi can help with, and what I hope we can achieve through interoperability and understanding how we connect the pieces, is that you don't have to spend a lot of money and create more barriers in your adoption of technology, so that when the policymakers catch up and they truly understand, and this will happen at the ballot box, of course, that the technology won't be a barrier for implementing the change that's needed. So it's definitely an issue with technology adoption, but once we adopt good technology, we have to have those systems talk, right? And so you see the likes of a Larry Ellison buying Cerner, thinking he's going to solve the interoperability problems that have been existent for the past, 30 or 40 years. And we know that's not going to be the case. Turns out he just wants to implement, Cerner in his own cloud, and there's all kinds of things. I can be as skeptical as I want, but the truth of the matter is, it does require an overhaul. It does require an overall and a shift of thinking, and it does require a real change in how we fund healthcare initiatives. And I'll say this one thing, it's a little bit of a double-edged sword that quality initiatives, focus on certain aspects. And then so, when quality initiatives highlight a particular remedy, and we want to be measuring quality in a particular care pathway, organizations that have the resources to put it in measuring and reporting have an outsized advantage in smaller organizations that don't have the resources, right, to do those quality reporting, which then impact rates of reimbursement and bonuses and other things like that. So it really is a mess that we've created, and it's all because we're trying to balance, this new shift from transactional-based medicine to value-based and quality outcomes, without focusing on what's in it for me and what are the underlying drivers, which are a competitive marketplace. And so it's always going to be that way for a while. I don't see the right mix in changing the balance, so that's something to consider. I hope that answered, at least from my perspective, that question. I think there's a lot to say. It's hard to unpack, but definitely a technology decision at every level helps an organization be more agile and more cognizant of the risk that the organization is taking given the headwinds of their competitive market. So it's very important that we understand that we're all rowing in the same boat in a given healthcare organization, and that everything we do can make a difference when it comes to an organization having to shift because of population health changes. And so that's what I feel about that. And that's certainly open for debate. We could have a wonderful discussion on that alone. What's the next question? I see another couple there.
Yeah, Sean asked, with population health management, what data do you think that we should be focusing on?
Okay. So that maybe comes down to the reporting efforts that one organization seems to be measured upon over another. So I know that, in the organizations I worked in, geographic areas, there was a focus of certain aspects of population that had a greater priority than if I was in another geographic area where I had a different group, a different cohort of pressures. And a lot of that has to do with how aligned we are. Again, it gets down to how we're being paid. It's hard to say what aspects. I think, obviously I'm going to touch upon social determinism in a bit, so maybe we'll get into that. But I think it is a much greater a spread of attributes and target areas that we need to be looking at when it comes to population health and overall reducing the total cost of care. We'll certainly be able to help ourselves by focusing on some of these priorities. So I'm going to touch upon that in a little bit. So let me move on. What I did want to say that in addition to the macro trends with population health, the trends in care delivery are changing, right? And I'm just going to touch upon this for a moment. And I was actually surprised to find out this number is much lower than I thought. When we think about value-based care and the move to quality, although these efforts, from crossing the quality chasm and these clarion calls from the late 90s, I think it was the late 90s or early 2000s, from the sorry, I drew a blank, but when these treatises were published at the turn of the last century, I think it was about 2000 or late 90s, we had a big quality problem, right? Unfortunately, that's where we had, I think, the number 3 reason why people die is just seeking healthcare in grand terms, and that can be due to medical errors, sepsis, these types of things, miscommunication, misdiagnoses, identity management issues, caring for the wrong person, treating the wrong part of a person, not having the right information, and having contraindications and the alike. The number is really large. How many errors and medical errors there are out there? And it was, at the time, it was the equivalent of multiple 747s crashing or that type of a thing. And then that came on the fast, and the heels was the checklist. Remember the checklist manifesto and all kinds of things. So basically, to achieve accountable care, to achieve value-based care, we got to be moving to a system that isn't so reaction focused, right? That we're not focused on transactional based medicine. And unfortunately, fee for service is still very much alive and well. I think we're only about 30% there. So when we think about those organizations which are value-based or able to switch to outcomes-based and move away from fee for service, again, because we're market driven, it matters where you are, what your competition is, who your population of subscribers are, and those things that cost the most to your bottom line. And so, without this equity stake, or this being able to draw a better budget, across all the lines, we're always going to have this uneven landscape. If you're in a geographic area where you have no competition, value-based care may not necessarily enter in the equation because you're going to pay, what that transaction cost is, for instance. So the mandates for implementation or timelines around this are more of suggestions at this point. And the way we lead with the stick, is to incentivize through interoperability and standards adoption, right? But even that has its constraints. So I just wanted to highlight that even though we're moving from transactional based medicine to volume-based care, and we want to get people out of those high cost centers and not be catastrophic when they first initially get to their PCP or their first involvement with their providers, that it's really hard to do, right? Again, we're fighting this market, that kind of wraps around every make. To that end, again, we want to be strategic with the decisions we make on the technology side, right? Now, moving into a couple of topics that are a little closer to that population health question, and another reason why we need to be thinking more strategically or outside our own organizations when we make IT decisions, and why I think E-IPaaS, in particular, a hybrid integration platform, is the way of the future for healthcare organizations, is because of this, surprisingly simple diagram. I was at an AI conference in Montreal earlier in the year, and a former ONC head with the Obama administration was there, and he put this slide up. I think it was Dr. What was his name? Vindell Washington. So he was a former ONC head and really helped a lot in advancing the initiatives around fire, for instance. And he put this chart up, and this is from the CMS, and it's really talking about, expectations around, what impacts your health outcomes, right? And when you stop and think about it, and the number is about 10% of that, the healthcare you get from your provider organizations, or that whole world of healthcare as we know it is responsible for 10% of our overall health and wellness. That's pretty eye-opening, right? So we need to be thinking about the 90%. We need to be thinking about the social, societal, and environmental factors, right, which impact our health. The water, the air, the environment in which we live, the stressors in our life, right? More and more genetics is becoming more apparent to us because of the available and the precise availability of our own genome presented to us through the retail marketplace. Now, I'm not going to talk about HIPAA in relation to these things when you enter into these agreements and get your genome handed to you with some heat map, and it tells you where you've migrated from and who your ancestors are. Ancestry is important, however, and so is your genetic makeup. But then your individual behaviors are very strong, an indicator into how your outcomes will be, right? So our present culture is rich with experience, right? And our current environments can offer the best in healthcare services, right? But because we're free to do what we want, right, we're going to have to deal with our, the inheritance of our genome, and really think about how we can lower the technical barriers when it comes to healthcare therapies, right? So the democratization of data becomes an achievable concept with the right technology, right? And so the overall 90% that is not in the healthcare domain, perhaps, is something that we're going to have to become more readily available to manage, right? So the methodology, the architecture, reinforcement, and the discipline around harnessing that 90%, if you do it right, it can have an outsized outcome to, how we're all going to live better. But, we're going to have to be thinking about this more strategically, because where we have a market-driven environment in healthcare needs to overcome this time to value equation, right? So let's see. Is there another answer? Is there another question here? Let me, yeah, okay. I see that one, Sylvia. Yeah, absolutely, right? Politics, to the extent that they are getting in the way of implementing policies that directly correlate to better outcomes, absolutely. There's lots of ways of getting in the way. Unfunded mandates is a really popular one. You saw a lot of that come to the fore with the epidemiology reporting and the CDC, the challenges the CDC had with COVID. COVID was an interesting time for all of us from a technology landscape. It really proved the efficacy and the value of the E-IPaaS market and the hybrid integration platform, especially for Boomi. We were able to help in an outsized way our customers and new customers, since they had to work at a disadvantage when it comes to being at arm's length, not being able to be together for technology or to implement new technology. We had to help customers implement, ways that they hadn't thought or budgeted for. And this is because, the government was creeping through aspects of reimbursement for remote care and telemedicine right up until that point. But with COVID, we kind of turned the corner, and it kind of forced people to make those decisions fast. And so we actually implemented infrastructure and architecture design in a matter of days, with our platform, because it's a platform approach. It wasn't just a product or an IT project approach, and I'll get more into that. And you're going to be seeing more of this, right? So again, it gets down to being responsible for what we can be responsible for, and unfortunately, we will be somewhat subordinate to the decisions of others, especially at the political level. Medicaid seems to have a better handle because that's more at a state level when it comes to cost control, but Medicare, when we think about costs at the federal level, those seem to be just exponentially out of control. And so we need to be watchful in that. Again, what we can do locally impacts greater for our local and competitive markets. I wanted to touch upon another driver for changers, right, in patient care. And on the right side, there's a graphic about social determinism, right? And earlier on, I led with E Pluribus Unum, that story from late May from about the lady who did not have care, and she was young, and unfortunately she couldn't get care because of her immigration status. And these aspects of social determinism impact maybe some of us, even though maybe we have good high quality care. And the things we have to think about are these 5 domains. Now, this is coming from a Healthy People 2030 initiative, and I put the URL at the bottom. This is from Health and Human Services. And it's important to know that, they are looking, right, to see what they can do to make an impact, right? Because they understand the 90%. They understand that there's so much about the care and outcomes of our citizens that are determined on what's happening outside the care delivery pathways, right? So they've identified 5 domains, and they try to give you those things which you can be looking at within your organizations, in your own policies and strategies when you're dealing with the public, that impact where we're born and live and learn and pray and, worship, and where we age in place, right? All of these quality of life outcomes and risks. Now on the left, that's really what the map kind of looks like when we think about social determinants of health. When you think about how things are blended together, when we think about the decisions we have to make as healthcare or health delivery organizations. And I'm not just talking about hospitals, I'm talking about pharmaceutical companies, biotech. Remember, they're all looking for pathways to the commercial market. Research collaborators are looking a way to close the loop to test their therapies for efficacy so that becomes mainstream therapy, these types of things. CROs, you name it. Supply chain, manufacturing, all these things are in the equation somehow when it comes to changing outcomes. And when we think about, hey, let's integrate Uber or Lyft in our website to help those high-risk patients get to their appointments on time. Let's look at those patients with COPD or other respiratory illnesses and the environments in which they live when they're not with us. Do they have an air conditioner? That's a popular thing. Do they have access to the nutrition that they need? Can we focus on diabetes management through the lens of a dietitian and not necessarily through the lens of, pharmacological solutions? So that's a big thing. So moving away from traditional therapies and trying to be more in line with healthy lifestyles, right? So if we're going to do that, we got to think about where the grocery stores are. What are your environments? When I send you home, is it really a safe environment for you to be in? Are those caregivers, your family members, actually able or willing to give you the care that you need, right? From a hospital perspective, from a skilled nursing facility, palliative care, and even unfortunately, in hospice setting, they're all looking for incentives to have people be cared for outside their high cost centers, right? It's all about reimbursement and managing the total cost of the life of the patient. but we need to be thinking about access and availability of the right environments in which we send our loved ones to. So I just wanted to throw that out there. When we think about social determinism, when we think about population health, it's very rich, it's very deep. When you think about building relationships with your affiliates and partners in your health network, you need to be thinking about how technology is going to help you connect to those systems. And I'll give you a quick story. Visiting nurses organizations, post-acute care, aged care centers, right? They have a very varied landscape, right? It's dynamic, it's unpredictable, and they have to connect to systems and connect to data points that are outside an organization's administrative domain. So you want to be thinking in a cost-effective way. How can Boomi help me connect to these systems that are outside? Can I do it in a secure way? Answer is yes, by the way, spoiler alert. Our architecture separates the design from the runtime, and we can talk about that in a. But you need to be thinking about how the technology you choose actually helps or creates another technical burden in your associations going forward and how your local market's changing. So I just wanted to show the difference between, although it's nice and neat to have 5 domains where you get a starting point, the reality is you really got this hybrid mesh already in which you need to be thinking about your patients and how they come to seek care. The business challenges, this is a little bit of a straightforward eye chart. It's really just more of a dartboard just to get you folks thinking about the types of problems people come to Boomi for when it comes to solving with the hybrid integration platform. We run the gamut from reduction of or reducing the dependence on point-to-point integration to higher cost, lower cost in the implementation of higher value outcomes. And it comes to some of the things they're doing, whether M&A. There's a lot of M&A, mergers and acquisitions going on in healthcare. There's a lot of divestiture that has to happen after an M&A, and none of this usually means they're reducing staff. What they're trying to do is create or gain an outsized advantage, right, in their competitive market. So you're seeing a lot of payers get closer partnerships or even buy more providers. You see a lot of providers tapping out of being physician-owned practices because the administrative burden is too high and it's taking the joy out of working with patients, right? So as far as the politics are concerned, you can see some of this effect is having in the marketplace where a lot of physicians are not happy delivering, on the promise of quality care because they are being stymied in their approach, right? They want to deliver individuality. They want to spend time with their patients. Their businesses are just being really hampered by the weight of the administrative burden. So there's lots of drivers at work here that a platform like Boomi can help with. Working at the edge with an IoT architecture or strategy. There are all kinds of things to consider. When we think about population health and value-based care and the physician or the homemaker, you could make this graphic anything you want, but the physician as an integrator, the GP, the hospital, and we think about the levels of acuity as we think about the continuity of care, and as we go around the care plan, or we think about all the connection points in a customer journey or a patient journey, we need to be thinking about where the data is coming from. How are we assessing the needs of the organization with what's around the corner? Are we really lowering the risk associated with care coordination with the technology we have? Are we really doing the best we can with complex case mixes and helping the visiting nurses or the attendants outside the high levels of acuity, manage or enforce adherence to their care plans? Do we have the right platforms or integrations with the right platforms to save money? If we're trying to lead to a lower cost and higher value outcome in terms of efficacy in my patient's health and well-being, am I doing everything that I can? Do I have the right tools, right? The tools can help in this regard a great deal, right? When we think about all the things you have to connect to. An EMR is great for that reporting facility that it does in the episodic care of the patient and allowing for all that it does within the service lines. But when we're thinking about connecting to the HR systems, to the payment, to the payroll systems, when we're thinking about onboarding and managing employees and managing the new relationships of bringing extended care teams online, when we think about all those SaaS applications, which are commonplace today, you don't need to be proprietary in your approach to integrating those things, right? And so that's another advantage. And we want to be thinking in these open and available ways going forward. The platform itself that I've been beating around the bush about for the past 40 minutes or so is a platform. It is a technology platform that is separated from runtime and design. It has aspects of a SaaS product in that's where you do your design in the cloud, but then the implementation of your business transformation takes place in whatever architecture that you choose on a Linux or a Windows machine as a platform for execution. We have EDI strengths in design. We have API management in the framework, user experience, a flow product to help in orchestration of a business transformation initiative. We can master entity relations, a master data management product, if you will. We call it Master Data Hub. And we can catalog and prepare data for your initiatives when it comes to data governance and readiness before you even do any integration, or if you're looking to just initially crawl and inspect and create metadata maps of what you have in your organization for better democratization efforts or for supporting your efforts in AI or ML, right? So the whole aspects of data governance are taken care of in our platform as well. And all these things are in an easy to use, low code, low cost and cost predictable platform that grows with any architecture. So you're not bound by architecture constraints as well. So I just wanted to throw that out there. We can talk later about that. But the reason why Boomi is such a strong product in enabling your business to be successful in all of the challenges that you face today is because we don't just do one thing well, right? We do several things well, and we provide it all there for when it's needed. I think one of the interesting things was what McKinsey and Company said. I got an email a couple nights ago. A lot of you guys probably get these McKinsey emails, but they're starting a new initiative, a multimedia program that in the next 10 years, right? They state that for many companies, and I'm going to read this because I thought this was apropos, because this was exactly Boomi's experience through COVID. And it's interesting that they highlight this, in that they state that for many companies, COVID pandemic set off a period of head-spinning change. And they realized that they were capable of moving faster than they ever thought possible, right? So it's never the case that the individuals can't move fast enough. They just didn't know that they had the permission to do so, right? So COVID kind of gave people the permission to do what they knew had to be done. Organizations went digital in a matter of days, not years. They offered new services almost overnight. And if companies sustain this newfound speed and agility, it's conceivable that more innovation will happen in the next 10 years than in the previous decade in modern history. And, that really resonated because that's the Boomi story through COVID. We really proved over our 21 years of history, that in this type of environment, this is truly, what can be achieved. And so many of our customers, it was a no-brainer for them to implement all types of controls in COVID, whether it was robocalling or more things at arm's length or, supporting of telemedicine or telehealth efforts. And it was because they were able to do modern integration and business transformation efforts at arm's length, right? They're really to take advantage of what the cloud can offer. And also with the cost constraints in mind, right? So I think it's interesting that McKinsey said that. It's just it's one of those things that makes a lot of sense. One of the biggest things that you can count on with a platform such as ourselves, and the reason why we're able to give such outsized time to value and cost savings, is because of our focus in the platform through automation, through our use of AI and ML and tooling that out of the gate with our platform does to reduce technical debt, right? With our platform, you don't have any fragmentation on the platform side. You don't map from scratch unless you want to. We actually have technology that helps you do application field to field mapping for you based on what others have done before you. There's no hardware incompatibility to struggle with. There's no coding requirements. We're a low code, no code platform. You certainly can use code. You can certainly use Java methods or .NET or other code that's supported on the underlying operating system, which our runtime exists on Linux or Windows. But we have tools, we have shapes, we have paradigms in play to help you achieve your business transformation and integrations with little coding effort at all. You don't have to regression test or upgrade in our environment. We can talk more about that. You don't have to worry about maintenance headaches. The installation is extremely straightforward, and it's not a closed platform. When you think of all these things in relation to what the legacy vendors do, they're all about supporting and enforcing their legacy and their enterprise licensing models, but we're all about removing technical debt and breaking those barriers. So I just wanted to share that with you. Use cases are outside the norm that you would expect. We have all kinds of wonderful use cases working with our partner ecosystem, and I wanted to share that as well. And that can be anything from devices, smart devices, wearables, activity monitors, near real testing devices. We've got interesting prototypes, supply chain use cases with our partner ecosystems with track and trace and security and GXP compliance initiatives. I see a question, what type of data are we talking about integrating? We have branded connectors, so we can work with Snowflake and all types of applications. We work with technology connectors. We have event-driven architecture support that supports different types of queuing. There's a wonderful article we have. It's kind of a dummies book on, I don't think it was a dummies book. I apologize to the authors of that. It is a full-featured text on enterprise data pipeline thinking. So if we're thinking about implementing a different type of queue or event-driven architecture type situations, near real-time eventing, Boomi can handle just about any architecture. So when we talk about what applications, we want to take it down to either technology or protocol level, document level, or we may have a branded connector, ServiceNow, Salesforce. We could be at that application or platform level as well. So we have hundreds of branded connectors, which also includes technology connectors. We treat everything as a document, and we do transformation accordingly in a repeatable fashion, so that you can take advantage of what I call the digital exhaust of one project over another. So when you do one project in the platform, it's not one and done. You don't start from scratch with the next. You can actually harvest the components and the integration methods and what makes sense to get a head start into the next, right? Because your organization is a living, breathing organization, right? There's no reason why your IT integrations or your infrastructure, your architecture needs to be static. With Boomi, we are a completely innovative and ever-changing organism as well, to the extent that you'd want it to be, right? There's no reason to be locked in with heavy developer presence if you don't need that. There's no reason to be locked in with feature sets that can't be learned. We offer learning for free on our website, and that when we have a strong community. So it's not that things change all the time. It's just that we are adapting and adaptable to your environment so that it's never a wasted effort. So take me up on that. I can explain further. That is a differentiator. From a security perspective, we're FedRAMP moderate. We comply with HIPAA compliance programs where there's a need for a business associate agreement. And from a controls perspective, I don't think I met, aside from some particulars of a government certification, of which I said we have FedRAMP moderate, we pretty much are able to abide from a controls perspective across industries. And that is because the data moves where the customer wants it to. So data doesn't go to the cloud or reside in the cloud. We don't have data residency issues where they don't need to be issues. We are global. We do follow Amazon's architecture, but again, things abide by their respective residency laws, especially with GDPR in Europe. So that doesn't become an issue. Again, that ends up being architecture, design, and follow through. So we have a question. Anyone getting providers refusing wearable integration into an EHR due to concern about it? Well, absolutely. So that's always been the issue with the connected patient and what a physician would want to attest to, right? Physicians always complain about the deluge of data. I think it's something that's going to become more and more easy to accommodate as EMR vendors and the wearable vendors become more aware of FDA regulations and they prove the efficacy of their devices. Initially, it was, real gross aggregation and uploading of anecdotal information. Hey, based on my Fitbit data or based on my Pebble way back when, or based on this, a physician only has so much information to go by or that they can attest to. So you do have organizations using retail activity monitors in their own care plans that are given to their patients that have a BIOS that when it syncs into their own cloud and merges with their own data, right? So you could have a Fitbit that has a BIOS firmware upgrade that syncs to a particular health plan's cloud and doesn't go through the Fitbit plan, those kinds of. So there are activity monitors that are purpose built for health plans because we want to pay particular attention to a cohort of patients that have a high cost because of these complex comorbidities, right? But yeah, there are concerns, and rightly so, because a physician has to attest, right? They have to be responsible. And so if the information can't be vouched for, as it were, or validated in some way, or they find it superfluous, I think it's something that's going to change, right? I mean, there's more and more people taking better care of their health and bringing better information to a physician. I think a physician will take that into account. But I certainly understand and have heard that, there is a certain pushback. They're already having to divulge more with notes and things with their EMR in further stages of inspection with transparency in the EMRs. Forcing them to take more input that they're not responsible for is going to be interesting. Is it the concerns over privacy hindering the adoption of more integration tools? I don't know. Privacy, as long as data can be shared, maybe remember data curation, data use agreements, all these things are important. So definitely data privacy is a factor in the use of integration tools, but really it's about, what's happening. Where's that data going? With Boomi, we're this hybrid, we don't have persistence, unless you design it that way with your E-IPaaS. So, we're able to address these issues around privacy. For other vendors, they may be a little bit more of an all or nothing approach. I hope that answers that. But it's really interesting to note that technology is really, is riding shotgun for all the things that ail us, right? As we become more, aware of the efficiencies in the marketplace. If I may just leave you with this thought, all of this is a common thread, right? That we've talked about. The platform, the decisions we make in the technology are going to impact, right? All these aspects, right? And the interwoven care pathways that we have to deal with in the day-to-day, right? So it's related to solving the dynamic problems associated with managing individual health and population health in the present and in the future, right? And the innovation, it's innovative and based on staying agile and open. So we need to be thinking about that strategically. We're utilizing environments and using solution equations to make things better. We're focusing on bringing everyone to be a part of the population solution, and it's supportive of casting a wider net amongst non-clinicians for more ideas and solutions. and to problem solve in the context of how we live our lives. So healthcare has to change, right? I know that was an earlier question, and it's changing to adapt to the needed scale and to conform to rising costs. And its challenges with volume and velocity dictate the population health dynamics that a legacy architecture cannot support. So that's going to be a challenge that we need to talk about. And I do appreciate the three pillars, Sylvia. The triumvirate, the triple aim, access to quality, affordability, and making it right an enjoyable experience. So these are all been great inputs and questions. So thank you for your time. Thank you.
Thank you so much, John. We'll see you here.